glad that we had almost 50 people joining us for this showing, and we're now shifting into the question and answer portion and the panel discussion. I'm going to give you a little bit of context, and then we'll have all of the other panelists introduce themselves, if that's okay. And also, we welcome thoughts, comments, and input through the question and answer interface that you have at the bottom of your screen. And if you really want to, I think we can also bring you up onto the Zoom stage if you want to open your camera up and join us as a panelist. So just a little bit of context here. I'm an emergency physician. I'm not a mental health professional. I didn't really know anything about this problem or the more general medical problem of overdiagnosis before I joined the Canadian Task Force for Preventive Health Care about 4 or 5 years ago, where there's a great deal of concern and focus on the problem of overdiagnosis, not just in mental health, but as it relates to almost every other facet of medicine. And it's through that connection and through an eye-opening experience of what I now see on a regular basis in the emergency department that I didn't recognize before, that I have landed the job of chairing the Overdiagnosis conference coming to Calgary in September of next year in some way, shape, or form. We hope it'll be face-to-face and that the COVID situation will improve. And this special showing is meant predominantly for the members of the planning committee who are joining us tonight, but there's some additional guests and friends who have come on board as well. And, you know, if I had to say it in one sentence, and I think the movie captures this amazingly, is that when you see harm, waste, and inequity, you have to do something about it. So that's why this has really hit a chord for me, and I'm now seeing a lot of waste and suffering in patients in the emergency department that have through some way, shape, or form been the victim of becoming medicalized when they used to be just normal individuals, which is the heart of what overdiagnosis is about. It's an international conference. It's been around for 10 years. In fact, a couple of the guests on the movie are regulars at the overdiagnosis meeting, Professor Alan Francis and Peter Goach, who you saw there. But let me stop there. What I'd like to do is turn things over to the three panelists to allow them to introduce themselves and make a few comments on the movie, and then we'll open it up to discussion. So, so thankful that Angie could join us on Thanksgiving Wednesday, where many Americans are celebrating with their families, either face-to-face or virtually. But as Angie mentioned, this is the 112th showing of the movie, and it's not surprising why this is so powerful. So Angie, I'll turn things over to you, and then we'll go to Val and then Ainsley after that, if that's okay.
Sounds good. Hi, everybody. You saw part of my story in the film. Now I work on the outreach team and hosting these conversations all over the world. We've done some pretty cool showings, all geared towards different either professionals or patient groups or nonprofits. Mental Health Europe was one last week, addiction conversations, all kinds of things. But basically, since the film wrapped, I'm 5 years off of all medications. I still probably meet criteria for everything originally, but I have to look for other ways to cope with the suffering, now that I have medical harm on top of it. So I do still suffer from some long-term neurological problems from taking the medications long-term. And I just do my best to try to remake the life that I feel like it was robbed from me a little bit. So I'm doing the best I can. And like I said, I'm hosting these conversations and really getting a lot out of the dialogue that's coming from it, that our stories are rarely talked about or even understood, especially in clinical practice. So it's great healing for me to talk about this openly. Oh wait, and sorry, and since the wrap, I graduated with my master's in social work, and I did an internship as an outpatient therapist. So I Sorry. So I was now I'm on both sides of the track, but I've decided not to. I'm not pursuing work like that right now. But so I did learn how to be a mental health professional with my lived experience. Okay, sorry, I always forget that part.
We're going to go to Valerie next. I really feel it's important to say one thing though. This movie is extremely powerful. It can be perceived as critical to healthcare providers and practitioners, even those who are well-intentioned. It's really not about that, I don't think. It's about really empowering patients and the public who have not yet become patients to be more savvy consumers. And the whole notion of the informed consent before you fill that first prescription, I think, is so powerful. So sorry, but I'll turn things over to Val for introduction and comments.
Thank you. And no, and I am a psychiatrist and I prescribe some of these medications, and I prescribe them because they save lives in some instances. But absolutely, I mean, I agree with the things that we saw in this film. There's overdiagnosis and there's over prescribing, and it happens a lot. The benzodiazepines, there's recently a petition to have them recognized as a controlled substance, and they absolutely should be. I agree with all of the comments, seeing people come in on years and years of benzodiazepines, that's abuse. And then people get really concerned when I have to refer to addiction specialists to help with tapering because it can be so complicated. And then people, patients would say, but I'm not an addict, I don't suffer from addiction. I'm like, this is where we are with this medication now. This is not a simple process, and we need to bring in specialists to get you off because your body absolutely is addicted. And you especially see it in medications used in children and medications used for behavioral disorders, things like autism, for which there's really no good indication. And a big part of my early research career was around trying to figure out how to get people to take seriously some of the side effects of these medications, particularly obesity, which I saw as a huge, huge problem. And people gained massive amounts of weight on these medications. And even if the medication worked, I felt like being forced to choose between, which chronic illness would you like to have? Would you like to have depression, or would you like to have diabetes? And that didn't really feel like a place where I was comfortable kind of placing my patients, so that they had to make those decisions. And so, there was one comment, and I think you actually just referenced it, Eddy, in the film. I'm not anti-medication, but I'm pro-informed consent. And I think that that's really, really important. I think it's imperative that patients lead the charge on this, and that they go in understanding the pros and cons of every medication, and kind of here's what we think we need it to do, here's the downside of it. If at any point you don't feel like this is working, or the side effects aren't helping, they're making you feel worse, that negates the whole point of giving you a medication, and so it needs to stop and we need to start again. And the concept of seeing somebody on 17 psychiatric medications I've never even heard of. I would be extraordinarily concerned if somebody was on more than 5. And even 5 is a lot, because once you get to that point, you're using medications to mitigate the side effects of the other medications, and you've created a vicious cycle. And so I don't see this film as being kind of anti-mental health or anti-medication. I think it's pro-patient, and that's absolutely where we should be coming from in mental health. Absolutely.
Ainsley, did you want to go ahead and introduce yourself and your perspective on the movie?
Sure. Hi, everyone. I'm Ainsley Moore. I'm a family doc faculty at McMaster University here in Hamilton, Ontario, Canada, just to orient, because nobody knows often where Hamilton is. I work with Eddy as well. I'm a vice chair for the Canadian Task Force for Preventive Health Care. Since 2013, I've been involved with the task force. And like Eddy, the task force opened a whole new window. As a preventive care physician, primary care, general practitioners, we're trained and we're positioned to think about prevention. And where overdiagnosis, overtreatment, and harms hit the metal, or put the pedal to the metal is around prevention, because you're taking generally well people, don't have symptoms, average risk, and you're putting them through something, some kind of process, some kind of intervention to hopefully make something better. And along that way, there's a high risk for harm. There's also, think about any screening example, the one that often controversial one that comes to my mind is breast cancer screening. And if you're thinking about screening across the different ages and in the younger women, you'll pick up more abnormalities, and you'll pick up more things that look like a cancer that need further investigating, that lead to harms to investigating, or you'll pick up something that sounds and talks like a cancer, but is actually a very benign condition that wouldn't affect a woman for their entire lifetimes, but now they're made aware of it. And because of the state of technology in oncology and breast cancer oncology specifically, there's challenges with figuring out which of these things that are described and labeled as cancers continue and which ones don't, and which ones stay exactly as they are. So they're all similarly treated as an aggressive form of cancer. And of course, that leads to other things. It leads to chemotherapy, radiation, surgeries at the very least, and carrying a lifetime diagnosis of cancer for a condition, a type of cancer that could never affect, would never become apparent in a lifetime. So those are the kind of, that's the kind of perspective that I'm looking at with this. This is mental health and psychotropic medications, which is sort of perhaps the hallmark or the iconic example of harm and overtreatment that I became a parent or became aware of in around 2014. I was looking at conflicts of interest I was looking through newspaper comments related to conflicts of interest in guidance and guidelines. And one of the areas that kind of lit up like a Christmas tree was around conflicts of interest in treating for mental health issues, and the issue of overtreatment and the issue of harm. Lisa Bolero was one of the leaders or investigators that kind of was someone that influenced a lot of what I was learning and what I was thinking. So that's the perspective that I bring to it. I just want to say thank you. Thanks, Eddy. Thanks for the opportunity, and thanks everyone. Thanks for the team that made this this film, and for Angela for your advocacy, your power, your optimism. You know, you're a real beacon and an authentic voice for this issue. So there's my perspective.
Thanks, Ainsley. And we are receiving a couple of great questions that we'll get to in a moment. I just want to clarify one more thing. I mean, one of the reasons we're putting this on is because we're hoping that, I mean, I'll have to go back to the planning committee on this, but I think this could be a really powerful part of another screening might be a really great part of the meeting in September, because we want our meeting to be more than just about healthcare providers. We want it to be about members of the public, patient advocacy groups, and even invite lots of media to get the word out about all this. So Angela, we do have a specific question for you, and it's from Kristen Van Ronson. It's about the powerful story that you've told. And if you wouldn't mind sharing what you know about your long-term neurological symptoms and why you think they're due to the medications, and what are the odds that the damage will recede completely and over what time span?
So some of the stuff I still live with is visual difficulties that are actually not visual, but they're coming from my brain, the way that my brain is processing light and motion. So I had a full workup from neuro-ophthalmology doctor at WashU, and he said, he sees the patients that nobody else can help. Like, we get to the end of our rope and we've gone to so many doctors, nobody can find us. So he's like, you're the third patient I've had like this week, you know? But basically I was diagnosed with visual motion sensitivity, visual vertigo, visual snow syndrome, but it's not my eyes, it's my brain. So I went through brain injury rehab for about 18 months. And it's basically classified as like an acquired brain injury, but no doctor is going to admit, like, I know this is so difficult, but they're not going to say like, of course it's due to the meds or the way that you were taken off the last drug. Nobody's going to say that. The reason that I know it's from the meds is because I was never like this until I came off the last drug. And it was like a light switch flipped, and all of a sudden I had all these symptoms. And the other reason is that there's a lot of patient groups, which is also controversial, that in absence of medical help for tapering off of psychiatric drugs, there's a lot of patient groups online. There's probably 100,000 case studies at any moment. You could just go watch the course of people's healing. And so it's almost like this collective wisdom that has grown over 40 years of people learning how to taper off the drugs. So you start to see like clusters of symptoms that are similar. And so I would fall on like one of the more severe sides, but this particular symptom, there's a bunch of them, but like balance disturbances, vestibular disturbances, visual, inability to drive, to walk downstairs, like there's these certain weird things that are happening that a lot of patients that have come off psychiatric drugs have. So I can't think that we're all delusional. Like it's in our collective wisdom kind of thing.
Thanks, Angie.
Oh, and then the doctor said, yeah, one last thing. You said, what are the odds the damage will recede completely and over what time span? So technically I would fall under like the protracted withdrawal syndrome, which it really isn't withdrawal after a certain point. I've withdrawn from the drug 5 years ago, but it's obviously changed the neuronal wiring of my brain, okay, because I took them for 13 years. So the brain doctor, the neuro-ophthalmologist, he said that people like me, he sees 50% improve, 50% don't. You're just going to have to take your time and just see what happens. There's no treatments, no further exams, no medications that can help this. We just have to see where you land. So I'm just holding on to hope, and I'm kind of at the acceptance point that like I took meds for a really long time. Nobody really knows what that does. I took large combinations like you saw in the film. It was 17 at the same time. Nobody knows what that does to someone, and here I am.
Thanks a lot, Angie. You know, if you'll permit me, it just opens another question that I'm wondering about. I mean, as an emergency physician, I keep on top of the emergency medicine literature, if it's about CPR or trauma. But am I right to say that there is an imbalance potentially in the mental health literature that, and maybe Val, you want to comment on this, but whether it's maybe just that I'm not looking for it, or it's not making its way into the high impact journals like the Canadian Medical Association Journal or the New England Journal. And I think we have to be careful not to put too, you know, the narratives and the stories are very powerful, but where's the data? Is the you know, we heard one person in the movie talk about roughly 30% resulting in harm. Is that something that's supported in the well done studies that might be under less influence from the pharmaceutical industry?
Well, I mean, I think it gets complicated when we figure out what you refer to as harm. But first of all, if you think about depression, most of the antidepressants don't work for most people. And only about 40% of people respond at all. And of that, only a small portion of them are able to tolerate it without significant side effects. And so is that because we need more research into better drugs so that things work better and are not causing these awful things? For sure, just like we do in cancer and other areas. But you know, if we think about, again, we think about obesity, which is the biggest kind of cause of kind of disability and probably mortality now, because it leads to so many other drugs. Some of the most commonly prescribed psychiatric drugs, if you look at the concept of number needed to harm, which is number of prescriptions needed to be written before somebody has a significant side effect or clinically significant side effect. And if we think about for obesity, weight gain of more than 7% of your body weight is considered to be clinically significant. Some of the most commonly prescribed medications, for every 3 prescriptions written, somebody's going to experience more than 7% excess body weight gain in a short period of time. That leads to risk of cardiovascular disease, respiratory problems, diabetes. And so in my mind, that's extraordinarily harmful. And those are not things that are necessarily taken seriously, or as seriously as they should be, by healthcare providers. And so I think that there's a lot of ways in which these medications can cause harm for sure, and without working very well for a lot of people. And so I think, again, the only thing that we can do as people who work in this field is to listen to patients. And when they say something's not working, or when they are having a side effect that's intolerable, we need to respect that.
Thanks, Val. We got a really cool question from Jim. I wonder if that's Dr. Jim Dickinson, who is on the planning committee as well. But his point is that, I think we can all be on board with informed consent. But when the patient is in front of you and you're either considering starting an antidepressant or an antipsychotic medication, or encounter a patient who you think may be having uh, some potentially adverse side effects or is at risk for withdrawal, where do you go to find that information? How do you do that key education piece? And I think that could be something that maybe Ainsley, you might want to, or Ainsley or Val might want to address for us.
Go ahead, Val. Do you want to start first?
Yeah, well, I mean, I would hope people just know this. I would hope that it's part of your medical training, or you recognize when you don't know something. Like they say, for when I encounter patients who come to me and are on massive amounts of benzodiazepines, I sometimes know that I'm going to need some help with the tapering process. And, you have to reach out to other experts. There's a lot of good literature out there. Most pharmacists are pretty well informed on some of the withdrawal pieces and how to do that. And so I work very closely with my pharmacy colleagues, but I also, I try to not get doses up to places that are much higher than they should be. But absolutely, I've seen people have extraordinarily difficult withdrawal symptoms after 1 week on the lowest dose of a particular antidepressant. Some people are extraordinarily sensitive. And I think the first thing to do is to, understand the patient's not making that up. And this absolutely can happen. And, be very responsive. And for me, I've sometimes used compound pharmacies, which are able to make medications that are off the normal prescribing doses. And so if the lowest particular dose comes as 20 milligrams, and it's either 20 milligrams or nothing, I'll work with a compound pharmacy if it's not a medication that can be cut, and we'll make 19 milligrams, and then we'll make 18 milligrams, and then we'll make 17 milligrams, and we do those types of tapers in order to help somebody come off these medications. I've seen patients who have to be hospitalized to come off some of these medications sometimes because their concern of seizure or other neurological issues are really rare. And thankfully that's unusual, but it's certainly not impossible. And so I think we have to be very respectful and responsive. I've also seen physicians who completely dismiss it's impossible that you're having withdrawal. You've only been on a low dose for a short period of time. This is not withdrawal. And it absolutely is. And for sure it can be horrific.
A lot of the, I'm in educating new trainees, new doctors, and one of our classes of medications that always has the red flag around it is a benzodiazepine. And so part of the training is use with caution and set up the expectations really fast and right up front. Addictions happen within 2 weeks of this medication. So plan on short-term use, plan on low doses, and plan the withdrawal, plan the taper, within that 2-week time frame. There's a list of drugs, Beers criteria, that identifies, medications that have high potential for harm. And it's mostly, this is considered in older adults. This is like our red flag drugs for seniors, but it applies to anybody that's considering any of these medications. And so part of that is setting up those expectations ahead of time. The problem with a lot of the mental health medications, they're termed legacy drugs, and they're legacy drugs because people are on them forever. And if you don't set up the plan at the beginning of how long this is we're going to give it this much try for this long, and then if this isn't working, then this is not the right way to go. Or you can expect this, you can run into withdrawal this quick and dependence this fast. So we just need to set up this plan ahead of time. And it takes a lot of pre-planned checking in and pre-planned topics to discuss at each of those moments. That's part of the training. and I have my sense is that they tend to be prescribed and they tend to be dispensed easily without a lot of this upfront consideration and planning. And so those would be the key things, to take away for any of our trainees that we're trying to instill these kind of concepts in ahead of time.
Can I say a few things just from the patient perspective? Informed consent. We see a lot of people in our support groups that they literally have never read the FDA pamphlet that comes with the drug. So one thing we always teach people is just go home and read the whole thing from page 1 to all the way to page 38. Read the entire thing before you put the first dose in your mouth. Like, you have to do that. That's just part of the process. So that basic health literacy piece is really missing for most people, just how to read or how to ask your pharmacist a question. And then the second thing I wanted to mention was informed consent, because the patient, about the language. Okay, so we have to be clear about the difference between addiction and dependence, because using the word addiction is kind of a misnomer, because what happens is the patient says, okay, well, I need to watch for craving, or if I run out early, that means I'm addicted. But these drugs are so physiologically dependence forming, or however we want to say that, there is no craving. There is no running out early. There's no buying them on the street. They're literally taking a small dose over a short period of time, and they're still becoming physiologically dependent. So we have to be careful with that language too at the beginning of the informed consent process. And then lastly, I wanted to say, because the patient doesn't have fully informed consent, they start to develop these symptoms and they're not sure what's going on with their body. And they might be having tolerance and breakthrough anxiety, and maybe even like tardive depression, where they have more depression than they did before taking the antidepressant. And so all these things start to snowball. They start seeking out medical treatment. They're like, what's going on? Something's wrong with me. I'm having heart palpitations. Like, all these things are happening. But because they didn't have informed consent, they go chasing these medical diagnoses, which leads to overdiagnosis. But then because the doctors don't have training to spot adverse reaction, adverse drug reactions, side effects, whatever you want to say, that the doctors can actually be tricked into thinking this is a physical problem rather than it could be coming from your medication. So there's like all these things happening at the same time that really could help prevent overdiagnosis and healthcare utilization, and just a waste of resources because the patient isn't informed about what they're taking and the doctors aren't trained to spot what's the difference between a side effect and a new disease.
Yes, thanks so much. Another couple of questions have come through and speak to a more fundamental issue about are we doing enough to train our nursing students, medical students, residents in both psychiatry and family medicine? Is there an awareness issue? Is there more that we can do to heighten awareness around the potential downstream harms of some of these medications? And Angie, do you want to start on that, or has that come up on the previous panels?
Oh, about medical education? Yeah, we actually, last week we had medical students that actually petitioned. They formed like a student union about conflicts of interest in medical education. Like, they wanted to know, is my professor, maybe pitching certain drugs, but honestly, I mean, I don't have a lot of hope, because I feel like the pharmaceutical companies are the ones funding. So it's like this big complex, problem that's happening education wise, even continuing education. Like, it's been hard for us to get into like addiction conferences or medical conferences, because to get CEs for any kind of information like this is like, what? No, you're not you're not teaching that. So we've had a little bit of a problem, but I do notice there's deprescribing, like the Canadian Deprescribing Network. There's a little deprescribing happening at Yale. So there's little pockets of it that does give me hope, but it takes the clinician seeking out that CEU course in the United States, at least, before they were trained in that.
Can I say CME is notoriously corrupt? I'm just going to say that. To get a CME program, continuing medical education program, you need the funding, and it often comes from pharmaceuticals, and the speakers are paid by the industry. I would say that education at the university centers, the hopefully. I think our learners and our clinicians are becoming very savvy when it comes to conflicts of interest, and they are becoming also more savvy in reading evidence. This is newer, but certainly the skepticism levels are higher, and the expectations for understanding trustworthy evidence, understanding what knowledge synthesis should look like and how it applies to practice. I mean, at least the centers that I've been working in, McMaster was the birthplace of evidence-based medicine, so it does come from a different lens, but it's been a long evolution and a long process to get there. But I agree with what Angela's saying about CME. That's a notoriously, I'm going to say, a corrupt area.
And I think sometimes people legitimately think because it's newer, it must be better, and that they're absolutely doing the right thing to help their patients by prescribing the newest, shiniest thing on the market that's got to be the best thing, and that's what they're hearing about in some of these CMEs. And one of the areas that I treat a lot is bipolar disorder, and this medication, when somebody's manic, they need a medication. This is not an illness that when it presents acutely, that talk therapy or other things are going to be able to be helpful later, but like in the acute presentation, some medications are needed. One of the oldest medications is lithium, and certainly lithium is not a drug without issues for sure, but it's a lot cleaner than a lot of the newer antipsychotics that are often used for this medication. And I'm just fascinated by the number of people who come in with this illness who have been started on the newest thing and have never been tried medications that we know have been around for a long time and are probably work better and are safe. But part of it is there's no money in marketing these medications, and so certainly newer physicians are not really getting taught about it. They're just getting taught about the newer drugs that are still unpatented and for which someone could get some money from. And so I think that we have to make sure that those things don't get lost in our teachings.
I think I totally agree with that. The shiny new item has attraction, and there's something called the pharmaceutical detail, where a rep will come to an office, present a new medication, present whatever evidence they've got on that, and that tends to drive prescription of newer, less tested medications. The other challenge is that there's the pharmaceutical cupboard, the sample cupboard that exists in physicians' offices. This is notorious because what gets stocked in that cupboard is the new products that the reps that are trying to promote. So the new drugs that pharmaceutical reps are trying to promote end up in that sample cupboard, and that's what's sampled, that's what's trialed, that's what's distributed. So a good place to start, get rid of the sample cupboard. It's not a bad place to start. There's lots of ways you can remove industry from influences. That would be one of them. The other things are take the swag out of the office. So the cups that the pharmaceutical industries, distribute at conferences, the pens, the freebies this, the freebies that, just keep the environment clean, keep the messaging out of your day-to-day thinking. Those are all these kind of strategies that are not hard to implement, but I believe in the long run can make a difference.
And that doesn't touch the problem we have with intellectual conflicts of interest. So if someone's done research on a drug for their whole life and is sort of has a particular perspective, they're obviously going to be the world expert on it. They might be invited onto guideline panels, and even if all of it was neutrally funded or had little or no industry influence, that commitment to that approach might make it challenging to have a really balanced view. We have, and apologies, I realize there are some additional questions in the chat window that seem very clinical in nature. I'm not going to go to those because I think they really need a one-on-one discussion with someone's healthcare provider. But Stephen's making a really good general comment about whether what we're seeing in this movie is really just symptomatic of a larger, frail, broken healthcare system, where in Canada at least, it often takes the time it takes to see a psychiatrist can be challenging. family physicians who treat the most mental illness in our country are under a lot of pressure and time constraints, and we don't have great ways of funding patients who need truly multidisciplinary care, whether it be in sleep clinics or somewhere that would be more appropriate for their problem. And often the prescription pad is the path of least resistance. So I don't know if there are thoughts from the panel on that particular comment.
I would say we'd all probably agree that there's lots of gaps and there's lots of ways that hopefully this could be made to work better. I think there is some improvement with the guidelines piece, Eddie, which is positive. I was involved in the publication earlier this year of the Canadian Obesity Guidelines, and I was part of the mental health section. And prior to even undertaking the guideline process, everyone had to complete disclosures. And so it was very clear kind of any conflicts of interest that were being brought forward, and that had to be vetted. And then the journal that published it had to review the conflicts of interest to see if they felt that the people putting together the guidelines were actually able to produce an unbiased document. And we were also mandated to have a number of people with lived experience as also part of the guideline process to kind of make sure that things seemed to make sense and that the whole process felt like it was above board and actually was patient-centered. And so that being in that process actually made me feel a little optimistic that at least there's some glimmers of things moving forward the right way.
One of the most hidden sort of conflicts of interest, even with as you're saying, clinical practice guidelines do have standards, international standards that try to limit the conflicts of interest across levels. Bringing in, the patient perspective is key to making recommendations that not only are relevant, but that can decrease bias. But one of a major hidden one is the conflicts of interest at the organizational level, so the disease condition level, or the specialty level, that you don't see that funding transmit down to the actual guidelines because it's not declared. It's not declared in the guidance. Even though those individual conflicts of interest are there, maybe the chair of the guideline, the authors on the guideline have really clean slates and that looks fine, but there's also a lot of hidden funding, and it may not have influenced the agenda, but it still needs to be declared. And even the journals have not kind of identified this source yet. I think they're eventually hopefully going to get there. They will. There's some behemoth organizations like the American Heart Association that punches out the guidelines, punches out the treatment recommendations that generate millions of dollars every year from different sources that come into play that you don't hear about.
Can I just say from, like, I don't know, as someone on both sides of the tracks now, what I noticed about learning to be a therapist was that all the patients that I saw had a real reason for their suffering, whether it be poverty, a crappy job, a husband that was abusive, immigration problems, the political, the pandemic. We have reasons for anxiety, right? So patients are starting to, with the spread of information and the ease of internet use, they're starting to figure out, like, wait, I don't want just a pill. Like, a pill's not going to fix my pandemic anxiety. Like, it's just not. This is the state of the world right now. So I think there needs to be more creativity in healthcare, where it's not just a prescription is the first thing. It needs to, like, look at the context of the person, look at where they're living, their socioeconomic status. Are they dealing with oppression in any of its forms, racism, and all these things, and take a more, it takes creativity, it takes time that doctors don't necessarily have. Because if you in the United States, it's like 8 minutes with the doctor and then you're out the door. So I mean, I always suggest, like, referring to social work, because we do look at more of the context of the person and what can we do with resources in the community, how can we get them housing. So there's a lot of things that we can treat outside of the hospital, outside of the doctor's office, that really help put the person at ease. I always like to tell this story about a person that I know wasn't getting along with her family, but she was also living in poverty. So we found her a seed exchange, and she got free seed and free dirt from the community. And her family built this great garden, and they were like every Sunday in the garden, working together. So like even those things are mental health. Like we don't think of them like that, but church is mental health, community service, like all these things. So I think we need to educate patients too, that there are things that you can do in your power. You might not have a lot of power in certain things, but there is things that you can do that can prevent, downstream major depression and stuff. And there's things in your life you can change, but it takes someone that believes in a patient, like you can fix this. It doesn't need a pill. Prozac is not going to take it away, but yeah, that's my recommendation.
No, and that's very key. And I think the pandemic stuff has really been challenging for me, because you also see, I think, very well-intentioned messaging about kind of, if you have anxiety, go see your doctor around the pandemic. I'm like, anxiety around COVID is pretty normal, and it's pretty healthy actually. And anxiety actually is causes self-actualization. People have some anxiety about COVID, they're much more likely to wash their hands, to wear masks, and to kind of engage in sort of preventative health measures that will protect them, than people who don't think it's a big deal and don't care about it. So anxiety around COVID is not something that we should be pathologizing, and you don't need to be treated for this. And people also conflate, exactly as you said, mental health and mental illness. And everyone has mental health. Sometimes you have good mental health, you have bad mental health, and we want to do things that are able to strengthen your mental health, and we can all be helpful for that. But I also think that the most valuable part of a mental health, a clinical care team for treating mental illness is social workers, 100%, because there are so many things that are feeding into someone's illness that, to your point, can't be addressed with a prescription pad. And it's around poverty and housing and all of those things. Absolutely. And that's where the system really starts to get broken, unfortunately.
I agree with those comments about the team approach. That there are family health teams that are fortunate to have mental health workers who are social workers or psychologists working alongside clinicians, nurses, learners. And there's also system navigators that have a really important role in figuring out what resources are available to people, what channels they have, what their needs may be, and walking them through processes, filling out forms, supporting whatever access issues they may need. Because you're right, when you're the family doc and you've got taking care of 1,500 people and you've got your roster full for the day, you're on a treadmill and you're trying to put the fires out. And so these teams really do step in to fill some of those gaps. They're expensive though, and they're not common. They're not commonly available. So there is an equity in terms of what people can access in primary care, at least in Ontario.
There's also challenges in the broader system. People work full time. Their employer's not going to let them take an hour off every day to come see their therapist, or 2 hours off every week to come see their therapist. Like they're just not supported. And so sometimes the only practical thing that they can do is take a pill and hope that it works, because coming to see a therapist is something that just won't be supported. I actually think, I hesitate to say benefit of COVID, because that's not the right phrasing, but I think COVID, the reality of COVID has made people more nimble in using virtual care. And I think that that's a benefit, that people can kind of now close the door in their office for half an hour and have an appointment with their therapist, or kind of go down to the lunchroom or go sit in their car and connect over the phone via video call with a social worker, a psychologist, a psychiatrist who's doing therapy. And that's actually, I think, going to improve things in the long run. Absolutely. Certainly, that doesn't replace face-to-face therapy for some people, but if, it's certainly better than nothing. And certainly for people for whom their life realities don't afford them the luxury of being able to take time off, moms who are at home with their kids and can't get childcare, like this can absolutely is having a positive effect, and I hope we continue with the virtual care options after the pandemic is no longer such a difficulty for us all, and because I think that that's been something that may help with some of this as well.
That's great. Super discussion. I just wanted to give a quick shout out to Alan Castles, who's been to a number of the previous Overdiagnosis conferences. He's from the University of Victoria and has published numerous books on the subject, including Selling Sickness. He's put in some really interesting information in the chat window related to conflict of interest and the influence of sales representatives from industry. Also some really good comments in the question and answers that have come through from places, from Gatineau, Gidentelio, who's talking about how educators there need to be much more forthcoming in declarations. So I think things are, maybe I'm going to draw things to an end. It's been a fantastic discussion. Super thankful to Angie for joining us on Thanksgiving Day, to the folks at Periscope Productions who made the showing of this film possible. Big thank you to Dr. Valerie Taylor and Dr. Ainsley Moore, who are joining us. And unless there's any final comments or thoughts that people want to share, I'll
just say that for the film, we do have, we're on all the different social media networks, and we also have YouTube channel with over 110 clips that didn't make it into the film as supplementary material, and panel discussions just like this one. There's about 30 of those. So if you have any comments, questions, if you want to do screenings, just email us at medicatingnormal@gmail.com. That's how you can get a hold of us. Oh yeah, and our website has the reading list, resources, alternatives, you know, ways to, there's tons of stuff on our website, and research. That's medicatingnormal.com.
Thanks so much, Angie. And if anybody wants to learn more about the Preventing Overdiagnosis Conference, I've got my email in the chat window. Want to thank again all of our everybody who joined us tonight. It's an amazing movie and very powerful, and I think it's leading to a lot of, hopefully will lead to even more positive, impactful change. So thank you. Have a good night, everybody. Bye-bye.